I think one of the most common condition I see in my clinic that doesn't get as much attention, maybe in the early stages of the workup, is cervical myelopathy. So cervical myelopathy is a constellation of symptoms, a group of symptoms that develop as a result of pinching of the spinal cord in the neck region. And when the spinal cord gets pinched, the spinal cord is the highway. All communication between the brain and the body has to pass through this highway. So if that highway go from 4-lane to 2-lane because there is pressure on it from a disc herniation, then traffic will slow down. So your brain is not going to be able to communicate with, let's say, your bladder or your legs or your hand in a way that allow you to maintain function. And doesn't have to be pain.
Today we're excited to have Dr. Abdulhamid, who's a neurosurgeon with Royal Spine Surgery, with us today. So thank you so much for joining us. So first off, one of the things that I find really fascinating is you not only are a neurosurgeon, but you do a lot of personal injury. People that have been in accidents, cases, you are an expert in that space. So what made you really want to start focusing on that side of neurosurgery where it was more trauma or personal injury or anything like that?
Oh, I think it's just by the nature of my specialty. We deal with trauma, we deal with injuries, and so it almost is inevitable. You're going to see patients that were injured whether through work, sports, car accidents, and so by default, I just happen to see these patients anyway in my clinic. And then after a while, you realize you get a letter in your office from an attorney, say we need now subpoena you and we want you to depose and give us opinion. And not that I wanted to do it, but I happened to take care of these patients, and that was part of taking care of them. And then after a while, you realize that that area, the attorneys don't have the medical knowledge that we have, and they need people like us to make their job easier, make the medical information understandable. So that's how it all started, honestly.
Okay, so I think a lot of people have misconceptions around how personal injury works. They get in a car accident, they have some other form of injury. There can be a lot of questions. They may be scared to go and see someone like yourself. So what would you say is the most common misconception that you've seen as it relates to people that have been in car accidents and injuries about going to see a neurosurgeon?
I think there is the fear of they hear the word surgery or surgeon and they associate that with I'm going to have surgery. And 80% of the time, that's not true. I mean, my involvement in these cases is essentially to ensure are the injuries severe enough to the level of needing surgery, and in most of the time the answer is no. But just because they don't have surgical injuries doesn't mean my job stopped there, because now I still have the responsibility of educating the patients and maybe create a blueprint for what I think is going to be a proper course of action in terms of conservative treatment. So I think the biggest misconception, they come to me and they say, well, doctor, I can tell you right away, I'm not going to have surgery. And I tell them I haven't said anything yet.
You're like, didn't say you need it.
No, I didn't say it. I just introduced myself. I'm Dr. Abdulhamid, good afternoon. But there is that level of intimidation that comes from going to a surgeon clinic, because the idea is you're going to tell me I'm going to need surgery. And I spent a lot of time just educating them on the injuries and the natural progression of things, and in most cases things are gonna heal. But there are times when we need to design treatment that can include therapy, injections, epidural, pain management. So yeah, 80% of the time I'm gonna tell them, you really good news, you don't need surgery.
Well, let's dive a little bit deeper on that. So you said that oftentimes your job, you said 80% of the time it may not be surgery, it's actually helping them to chart a course of care so that they can get back to the goals that they're wanting to live. Can you give us some examples of somebody that, let's say, was in a car accident? What could a conservative course of care look like that you may chart out? And not to say that this is what you do every time, but just an example of what may be included for somebody that maybe they're in a car accident and they're like, where do I start? What do I do? What could it include?
So I think anytime they get into an injury, the first thing they're going to try to rest for a few days just to see if it's something that's going to go away on its own. Sometimes that's not the case, and now they might develop more spasm, more stiffness, limited range of motion, discomfort and pain. And then they're going to start typically with what I call the tier system. So tier 1 is going to be more of the rehabilitative treatment, and that's going to be the umbrella that include chiropractic therapy, physical therapy, massage therapy, acupuncture of some sort. And then that will be kind of like, maybe 6 weeks on average.
Hmm.
That should gives us an idea after 6 weeks if they're
If
going to
it's going to
actually do
help or it's
it's not
not, work. Yeah.
exactly. And then if we think that that's not going to help, now we go to tier two, which is more of that pain management interventions. And now they need to see a pain specialist that they can consult them and do injections, whether it's the steroidal injections, medial branch block, radiofrequency ablation, whatever. There is, they have in their toolbox, they have option where they can actually get to the source of the pain and inflammation and swelling to try to reduce that. And the idea is we want to get to that pain in the acute phase so it doesn't become a chronic pain and now it's hard to manage.
Hmm.
And sometimes they go through that and they're not getting the relief they want, so now they send it to the surgeon to say, do you think this is surgical?
Hmm.
And 80% of the time we look at the MRI, the images, and patients say, you really don't need surgery, but we might find things that they might not have been discussed or explored yet.
Hmm.
One of the common condition I see is facetogenic mediated pain, where the facet joint is the source of the pain.
Yeah.
They don't have a disc herniation or pinching of the nerve, and then we say, well, we might want to send you back
Yeah.
to the pain doctor for the RFAs now.
So how common do you see that people mistake facetogenic pain with radicular pain?
Oh, it's very common.
Right?
Yeah.
So just for anybody that doesn't know, so both of those are going to have referred pain, right? So radicular pain is going to be pain going down either your arm into your hand or down your leg into your foot, right?
Exactly.
That's going to be neurological based, usually from like an inflamed disc or even a facet that's impinging on some type of nerve, right? And that's going to cause that lancing type pain that we hear.
Exactly.
Shooting pain, it's often described by with patients, versus referral pain is going to be not necessarily from a nerve, but nerves are involved, but it's not the direct compression onto a nerve. It's more likely to be a facet that's inflamed, and that's going to create a referral pattern. So why are those so often mistaken? They come to you, they're like, I've tried this epidural and I've tried this care, and then in the end you're like, yeah, it's because they're treating the wrong space. It's a facet that needs to be treated. So why does that happen so often? Do you feel like that's confused?
I think honestly it comes down to the medical community. Us doctors, sometimes I think we use terminologies interchangeably without understanding, like without sticking to a true definition. So sometimes a patient come to me and say, well, the doctor told me I have sciatica. And I'm like, so tell me what that means to you. And then they start talking about their hip. And I'm like, the patient interpretation of their pain might be misunderstood. So sometimes spend the time to try to truly understand what does that pain mean to them. That's one component. The second component, I think, is we rely heavily these days on imaging studies.
Yes.
So the first thing we're going to look at is an MRI, and we are programmed to look at the disc. Our first suspect on any MRI is always going to be the discs. And so if we find a disc bulge or a disc herniation and the report says 2 millimeter here, 3 millimeter here, we think the disc is inflamed, to your point, and now we think it's going to be a radicular symptom, so let's do the injections.
Yeah.
And I find it interesting because when I started doing personal injury, it was very rare to actually see the radiologist commenting on the facet joint in terms of facet joint effusion or edema.
Yeah.
Things have changed, and now we see more reports focusing on, or at least paying attention to the facet joint, which help aid with the diagnosis, which obviously help aid with proper treatment.
Yeah, so just to give an example of this, you could have a patient, and the way they'll present is, I have pain that goes down into my butt or the back of my leg.
Right.
Right, and so, okay, let's get some imaging.
Yeah.
And we get some imaging, and it shows a bulging disc. It's very easy to go, oh, okay, well, that means that the disc is causing that pain that radiates in the back of the leg. But you can have a bulging disc and have no pain from that.
100%.
Right?
100%.
And facets and discogenic pain and facetogenic pain can appear very similar. And that's why we do some of those orthopedic neurologic tests, and there's different ways that we can differentiate those. So when you're working with a patient and you get to them, how are you differentiating with that patient, whether it's going to be facetogenic or discogenic?
So the pattern is going to be different. So one quick way for me to screen that, which is very easy, and I put that in my intake form with all of my patients. I tell them, if your pain is $100 bill, and I try to actually force the patient to think hard about this, and I tell them that $100 bill, you're going to split it between two people, and the two people are your back and your legs. How much of that $100 you're going to give to your back, and how much you're going to give it to your leg? And if it turns out that they tell me that most of their pain, like let's say 60-70% of their pain is the back, and then 30 is the leg, to me that favors is going to be musculoskeletal
Yeah,
facetogenic.
yeah.
If they tell me no, 70%, 80% is the leg, the back doesn't bother me as much, I'm going to think it's probably radicular.
Yeah.
And then that will guide me in my examination. So I'm going to look into certain maneuver. So I'll actually do facet joint loading tests where I actually
Like a
press on the
Kemp's
facet.
or
Exactly. And then if they're positive, then now that make me lean more toward the facet joint.
Yep.
Versus, let's say they have a positive straight
leg
raise
raiser.
when that's radicular. And then we look at their MRI, and now you're kind of building, you're adding more evidence
Yep.
to confirm that this is.
I think that's actually a really beautiful way of describing how good doctors do diagnostics, right? On an MRI, we can diagnose whether you have a disc bulge or not really well.
Right, right.
But we can't say whether that's what's causing your pain.
100%.
Like, what's causing your pain is going to be building this base of evidence. I'm going to take the imaging, and I'm going to take your history and what you told me, and your activities that are limited, and my orthopedic tests, and I'm going to take all of this, and ultimately that's where I'm going to come up with my differential diagnosis and ultimately diagnose that patient. And I think that's really where the art of medicine comes in when it comes to diagnosing, is being able to put these patterns together and say, this is what you need for care, because I've diagnosed the right thing, I can now treat the right thing. Because oftentimes I think people don't realize that the care that people might be getting, it could be exactly the right care, but it's for the wrong diagnosis.
100%. You're absolutely right. And I see that a lot. Yeah, you're right. And they come to me and tell me, listen, I had the epidural injection, it did me nothing. And they think that somehow the pain doctor failed them, they didn't do the right thing, or maybe they just have an odd body that doesn't respond to treatment. I tell them, no, that's actually a good piece of information. The fact that you didn't respond to the epidural injection
tells us a lot.
Just verified to me that this is not a radicular issue and the disc is not the suspect. Now let's look at the facet joint. Have you had facet joint block and RFA? And they say no. Well, let's try that. And then they try that and they come back and say, of all the things that I tried, doctor, that made
That's the one that did it.
That's the one that did it. That's perfect. So now, even when they don't respond to treatment, I try to educate my patient, tell them, listen, just because you didn't
wasn't a
respond
waste
to
of
treatment,
time.
that's not a waste of time. That's actually by process of elimination, we're actually getting closer and closer to the source of the pain, because you said it. The MRI doesn't tell me where the pain is coming from. The patient, their story, their exam, the pattern is what tell me where the pain is coming from.
Absolutely. I think that, when you work with good doctors, one of the things that you realize very quickly is that the best doctors are going to take time to really try to understand the patient. And when you take the time to understand the patient, that's where you're going to be able to deliver the best care. And it's because of what we just said, right? Is that you can be the best treating doctor in the world.
Right.
But if you're not the best diagnostic doctor in the world, you're always going to be limited by your ability to diagnose, no matter how good your treatment skills are, right?
True.
And so really being able to say how important the patient's story is, how important listening to them and understanding that goes into creating and finding the right diagnosis is huge. And what we found is that when you bring a team of people together, different types of providers, the likelihood of you getting that right sooner goes up dramatically, because you have different people that are saying, well, this is the part they focused with on me, and you might say, well, this is the part they focused on with me. The truth is, patients tell different types of doctors different things. And they're all true things, but they share different parts, right?
Exactly.
So how have you found collaboration with the different types of, you mentioned that you work with chiropractors, acupuncture, physical therapy, pain doctors, all these different people. How do you try to make sure that you're collaborating and building off the care that they've already done to make it to where you're not having to start from zero every time you see a patient?
I think it's a lot of it's just building, trusting that every specialty is gonna do their part. So when patients come to me and they say, "Listen, do you think the chiropractor is the right thing for me to do?" I tell them, "Well, you're in good hands. The chiropractors are doing their part, but that's part of the puzzle." I mean, I tell them when we talk about pain, personal injury, or side of personal injury, I look at it as a big piece of puzzle. And on the different pieces are the different components. I'm just one piece, and the pain doctor is one piece. And these pieces have to come together for us to paint this big picture for all of us to understand it. So I collaborate with my chiropractors, with the pain doctor, and I put it in my note. Sometimes patients come to me, and they really come to me, we know that they don't need the surgery, but it's more kind of like, hey, like FYI, are we missing anything else? And I look at the patient and say, listen, you're actually doing the right thing. My recommendation is complete the chiropractic care.
Keep going with what they recommend.
Because it's working, it's helping. If it's working, keep doing it. And sometimes I get it. We want our Starbucks coffee yesterday, not in the next 5 minutes, right? So, and patients, when they're in pain, they want the relief immediate. And I tell them, listen, these things can take some time. So I try to set the expectation with the patient and make it realistic. Say, listen, this is not gonna like go away. You were in a car accident. It was like high speed, that kind of stuff. So set the expectation right. And I have an open policy with the chiropractors and the pain doctors, because I don't think that one person knows it all, right? So we all play our part. They come and ask me questions about medication. I tell them, listen, I'm the last doctor you want to talk to about chemicals and drugs and dosage, because that's not my language.
Yeah, you're a surgeon.
Your pain doctor is more qualified to talk about that kind of stuff, so I'm going to refer you to them. They ask me sometimes, hey, listen, do you think I should continue the chiropractor, or can I do chiropractic? And I say, listen, I don't control their board. I can't say what they can and cannot do, but you're in good hands. The fact that they sent you to me should tell you already that they're trying to do the right thing, and get a second pair of eyes to make sure, we're doing the right thing for you. So having that open communication, open policy, that there is no bad questions, no wrong question, and I feel sometimes people might feel intimidated. Should I actually bother the surgeon and ask that question? Is that going to make them think different of me? Not really. I don't know all the answers, and sometimes I need the input from other doctors too. So,
well, I think it's really great in what you said, which is all of the doctors do, like if it's a good doctor, and generally speaking, people work with good doctors, so they know what they're doing and what they do works. Right. But it's almost like a Venn diagram, right? Of you've got this circle here and this circle here, and there's overlap on care of when you're in their specialty and the area that they are really good at, they're going to help really well, right? But that doesn't mean they can help with everything.
Yes.
Right? And so you brought up chiropractic, and chiropractic can help on some really great conditions, but they can't do everything, right? And a pain doctor can help with some really great conditions, but they can't help with everything. And a surgeon can help with some really good conditions, but they can't help with everything. And so I think that whole process that you talked about of really making sure that you're communicating both with the doctor and then also with the patient, reinforcing, hey, if this is working, you're doing it, keep going. Like we don't need to keep going, well, how do I get there faster? And how do I get there? I wanted to be at this point, last week, and I'm here. It's progressing too slow. It's like, if it's progressing, sometimes things go fast, sometimes things go slow. But in the end, the goal is to get you to the destination. It's not a matter of how fast or how slow. It's to get you to where you need to be. And I think that's a really important conversation to have with the patients. And I like how you describe talking through that with patients. So changing gears a little bit on this, you talked about people that have facetogenic pain. I'm going to bring us back for just a moment on the facetogenic pain and discogenic pain. So pain that comes from a disc versus pain that comes from a facet. When patients are experiencing that, I know a lot of patients may listen to this and go, you know what, I've had back pain. I've been getting, an epidural, or I've been getting a RFAs, and it doesn't seem to be working, right? What advice would you have kind of for that patient that, they're getting one thing and it's not really working, and maybe they need the other thing? How would a patient know, and what steps should they take to find out? If they're getting an epidural, it's not working, maybe they think that they need like a facet block or an RFA. What's the right steps for them to go through to know which direction they should go?
I honestly think, and actually I've encountered that even in my clinic a few times, and to be honest with you, I think we don't do a good job in the medical field in spending enough time to educate our patients. Like, for example, when patients come to me and ask them, hey, you've seen your pain doctor, yes, you've had interventions, yes, you had injections, yes. Well, what kind of injection you had? I don't know, they just stuck needle in my back. So the patients don't even know what type of injection, so they don't have that level of understanding of the differences, because for them an injection is an injection. All they see is a needle going through the skin, but they don't know where it's going or what it's delivering.
And what the intent is,
Exactly. So sometimes I find that, hey, have you had epidural injection? Oh, I think I did. And then I have to ask them, well, can you tell me what they did on your back? And sometimes by showing me on their back, I get a feel, okay, that was more like a medial branch block. That was an epidural. But spending that extra time with the patient to help them understand, or maybe even when they leave the pain doctor office, maybe they have their own diary that actually show them, here is the epidural and the level and what they're intended for, here is the medial branch and RFA, so they have understanding that they're not all the same. And I think that's the mistake, not the mistake, but the misconception that the patient think that all injections are the same. and they put it under that one umbrella when it's not. So I spent time educating them on that and say, listen, no, the injections you had were intended for radicular symptoms. They didn't work because you don't have radicular problem. Now I want you to go back to the pain doctor and we're going to discuss doing medial branch. So why didn't they do that from the get-go, doctor? Well, there is a step that they have to go through.
Yeah.
And there is a process of elimination. They can't give you all injections at once because if your pain went away, now we don't know which one did it.
Yeah, some things are both diagnostic and therapeutic, right?
Yes,
And
yes.
so I think that's really important. They can give you relief, but they also tell us something of whether we're at the
Exactly.
right spot.
Exactly.
So I know that this holds true not just in injections, but also in surgery.
Right.
So, we've had the chance to talk to a lot of neurosurgeons and orthopedic surgeons, and one of the biggest concerns that patients have is that they're going to have, they have back pain, or they have what they say is back pain, but maybe it's radicular pain with back pain.
Yeah.
And they're afraid that they're going to have surgery, but still have back pain. And this whole dynamic of facet versus disc and where the pain comes from is a similar play here of, you'll have patients come in and they said, you sent me for surgery, I had surgery, and I still have back pain.
Right.
And the question is, well, do you still have leg pain? Like, well, no, my leg pain's gone,
Yeah.
but I still have back pain.
Yes.
It's like, okay, well, that doesn't mean that the surgery didn't work.
Exactly.
Right? And so when you look at this, I think it's the same thing of what we were just talking about, just
pain,
at a surgical level versus at an injection level.
Right.
If you have discogenic pain and it's causing radicular pain and you have back pain, so that pain's going down the leg, back of the leg, true sciatica, any of those things, you go in there and you do a microdiscectomy or something like that to take, you essentially you're decompressing the nerve, you're trying to take pressure off of the nerve, and that's successful. That radicular pain should go away, but that's not going to affect your back pain at all.
Exactly.
Because that's not the intent. The intent was to affect the radicular pain. And so I think that's another place that one of the reasons why so many patients are frustrated with surgery sometimes is not because the surgery didn't work, but because they didn't necessarily understand the intent behind the surgery. Just like you said, they didn't understand. They're like, I had back surgery, but I have back pain. It's like I had an injection, but I still have leg pain. And so how can we do a better job educating patients, whether it's for surgery or whether it's for other procedure, to make sure that they understand the desired outcome?
So this is now going to be an interesting topic, the one that I'm passionate about. I also think the problem is not that the doctors don't want to educate the patients. When you're dealing with insurance-based world, time becomes very limited.
Yeah.
So how much time do I get to spend with the patient to go over all of that? And when you are actually seeing 40, 50 patients a day, that allow you maybe 5-6 minutes with a patient, and that include talking, examining, looking at images, and finishing your note. And then talk to your office about, schedule or whoever about the plan. It becomes very difficult. So then we become very dependent on these MRIs. So that's one thing that I realized, that I spend 1 hour with every patient. A full hour. Every initial evaluation in my office is a 1 hour, so I can actually spend that time. So to your point, I go over what you just said. If I'm going to do a discectomy, I know your leg pain is going to go away. But remember, you told me 70% of your problem is the leg. And you said that 30% you can live with. Now, what I also learned, and I tell my patient this, human beings, we're greedy by nature. Once they get that 70% relief after the decompression, like you said, they come back and they say, but my back hurts. And then I remind them of our conversation. Remember, I told you that that's going to happen. But most of them, they understand. But setting the expectation up front, I think eliminate a lot of the frustration on both ends, the provider and the patient. So most of my patients, they come to me and say, no, I remember you told me about that. So I'm okay with it because it wasn't something that came as a surprise to them now. But I think is finding the time, which is hard to do when you're running busy practice and having so many patients. But again, I think it's the insurance-based medicine where it becomes a volume game because the reimbursement keep going down every year.
Yeah.
So.
Yeah. So speaking to, there's 2 points that you talked about. One of them is the unfulfilled expectations. There's a saying that I like that says, the origin of all disappointment is unfulfilled expectations.
True. Yeah,
right? And I really believe that. And so in essence, you're saying that the reason that patients sometimes have a poor experience isn't because they had, a poor outcome. It's because their expectations of what they thought was going to happen didn't happen. They could have 70% relief, which could be fantastic, but if they were expecting 100, they're disappointed.
Exactly.
Right? And so one of the most important things that we can do as doctors is set the right expectations for what could happen from a procedure, from a type of care, from the outcome they should expect. And I believe that when we do that well, you have patients that are really happy. And when you do that really poorly, you're going to have patients that are going to be disappointed, even though your quality outcomes could be exactly the same.
Exactly.
Right? So that's the first part of that. The second part of that, I think, is really interesting in the fact that you say, we have increasing premiums. People feel like they're paying more and more every year, and the data supports that. Their premiums are going up. And then you also have decreasing reimbursements to doctors that we're seeing that they're going down. And unfortunately, when you're charging more for premiums, you're paying less to doctors. Well, that money's going somewhere, and unfortunately, I think most people suspect where it's going.
Exactly.
But at the same time, it does create a conundrum in the healthcare space of you're trying to deliver the highest quality of care possible. You care about your patients. You want them to get better. And yet at the same time, because there's less and less reimbursement for the procedures that you're doing, you also want to keep all your employees, and you want to keep the lights on, and you want to make sure you can provide for your family. So this is an interesting conundrum that many, many doctors handle. You said you spend an hour with patients. How have you found that you're able to spend more time with patients and deal with this conundrum?
Simple, quick answer. I stopped doing health insurance medicine.
Yeah.
So I got myself out of it because it got to the point where I was, what you said was true. I mean, it got to the point where you have to see more patients than you can physically, are able to do.
Yeah.
And then when you get to that volume, you know what happened, which you said it perfectly. To see that volume, you have to have enough support. So you're going to hire more staff, which means your payroll goes up. Now you need to and then next year the reimbursements go down, which means I need to now increase the volume and I need more staffing support. And it got to the point where I didn't feel like I was actually practicing medicine. I was just kind of like a labor, like working in a factory. And I was just like fitting into someone else's agenda, and that wasn't satisfying to me. So I had to make a decision a few years ago and said, I can't do this. This is not what I went to school for. I want to spend time with my patient and talk to them. So we had to adapt a model where we tell the patients, I don't take health insurance myself. Now we can use your health insurance for ancillary services, other things, but for me to spend that time with you, I cannot have health insurance value my time at $20 copay. Do you value your spine at $20? So, and you're asking me to spend time with a complex topic and looking at MRI and looking at picture and looking at your story. That cannot happen in less than an hour. And so here is my hourly rate, which is interesting because I actually started doing that even with the provider that I and my family go see. And I started doing this experiment where I would actually go to the doctor, like my wife, went to the doctor the other day, and I was like, listen, would you mind, how much would it be if we just pay cash for the visit? And it wasn't actually that much higher, honestly, than the insurance, but at least somehow the doctor now is spending an hour with us.
Isn't that amazing?
Because, but you leave and you're satisfied. You get the answers. So I don't think doctors are bad.
Yeah.
Because sometimes patients come and say, "Well, doctor, they spent time with me, and I didn't understand what they were saying." I was like, "Please understand where they're coming from. They're not bad people.
Yep.
But there's limit to what they can do." And I was there a few years ago where I was like these doctors. I would walk in and just look at an MRI, and it's either surgery or not surgery.
Yeah.
We're making decisions based on MRIs and not looking at the full picture.
And as we just talked about earlier,
Yeah.
that's not necessarily going to lead to a great outcome.
No.
Yeah.
No.
So what you just described, I think, is one of the major reasons why we're seeing doctor burnout. There's a lot of potential reasons for doctor burnout, but one of the theories that I'm most fond of is the fact that what you just said, when you're having to see more and more patients, you're trying to hire more and more staff, you're trying to run a busy office and try to take care of your patients. You care about your patients. You went to school to be able to take care of patients. Yeah. And the more that we see reimbursements go down, the more doctors are trying to see more people. Yeah. The less that they can care about their patients because they can't even spend the time to necessarily build the bonds and relationships with them. It's not that they don't care for them, it's that it's hard to build relationships with them.
Right.
And at that point in time, when you cross a certain threshold, you feel like what you just described, which is you feel like a factory worker where every patient's a number rather than they're
Right.
individuals that need help. And I think that has led to an increasing amount of doctor burnout is as soon as you stop seeing them as individuals, patients as individuals, and you start seeing them of, I need to see this number of patients to keep my lights on, I think very quickly, not only does the quality of care go down, but more importantly, the amount of care that you can give to your patients, and let me rephrase that, how much you care for your patients
Right.
starts to go down. And at that point in time, it's not worth it. And that's where we see that burnout is patients go, doctors say, you know what, like I went into this to help people and I don't feel like I'm getting that anymore.
Yeah,
And
right.
that's to me, that's one of the reasons we're seeing a huge increase of burnout is because we're seeing decreased revenue. You're having to see more patients an hour, and when you see more patients an hour, you can't build the actual relationship that a doctor should have with his patients of, I care for you, let me listen to you, let me see how I can help you. And ultimately, that's what's needed to have that strong doctor-patient relationship. My opinion, but
No,
I think it's a good theory.
I agree with you 100%. And I can tell you, like, the issue with burnout, like physician burnout, it's real. It is very real. And something we don't talk about even as provider, even among ourselves, because obviously, you probably know this, almost every doctor is a type A competitive because from day one you go to school and you want to ace every
You're going to
class, and right,
compete. Yep.
you're always like approaching life with a competitive nature. And we don't talk about this. One thing that I realized that mental health is a big component that doesn't get discussed or addressed even among doctors and even in our community. You probably already have
Absolutely.
heard of. We've had a few really promising good doctors in the last several years that committed suicide.
Mm.
And obviously I don't know the details behind like all of it, but to your point, they were people that I consider colleagues. I would see them in the hallway in the hospital when I would go and do my cases, and then one day you hear that they're no longer with us, and the reason is suicide.
Mm.
And you would ask what went wrong, and part of it I think is the burnout, the mental health, and that's a topic that I think most of us don't openly talk about. And I can tell you personally, when I was doing insurance medicine and I was seeing 50 patients and doing crazy number of cases, and never see my kids and never see my wife, and I used to take trauma call, which is Sunday morning to the next Sunday morning, and I was a different person. I wasn't like I
So you
wasn't.
feel like since switching away from insurance, you have better mental health now?
Oh, 100%. I mean,
That's
maybe my
interesting.
family can tell the difference now. They're like, are more, like you're more laid back. You're not as, you're not as intense. And think about what that does even biologically. When you're under that kind of stress, your cortisol level is probably like super high.
Until it goes to fatigue and then it drops and you
Yeah,
can't
exactly. And
produce
you
it anymore.
crash, and
Yep.
so it wasn't a healthy setup for us because I was like, you're gonna like age faster
Yep.
and die sooner. But then you're not, it might not be a fulfilling life because you
Mm-hmm.
don't feel like did what you went to school for, which is take good care of your
Yeah, you
patients.
stop enjoying life and just try
Yeah,
to get through life. And I think that for anybody that catches themselves in that situation where you're just trying to get through the day rather
yeah,
than enjoy the day, you're starting to potentially have some mental health issues.
yeah,
And
yeah.
it's probably worth talking to someone, whether it's, there's so many different options out there. We had a really great interview on the podcast with Dr. Don Fowles, who's a psychiatrist, and we talked about this. But there's like great therapists don't need to be licensed necessarily.
Sure,
Like, right, you can talk to your friends first. Like,
friend.
you can talk to, a guru, a mentor. Eventually, you should definitely, if things persist, like escalating to like a therapist and then
Therapist.
a psychologist, psychiatrist. But like getting professional help does become important. But if you're in a place where you don't know, like speaking and talking is the place to start. And I think you just said that so well. Sometimes it's so hard to talk about these hard things with people, but ultimately starting the conversation is when healing can start to happen. And if you're
Right,
not
right.
talking about it, there's not going to be any
Not gonna
healing.
help. There's
Yep.
not gonna be help. You're right. Yeah, and it's unfortunate I think because I think maybe there is stigma, but at the same time I look at myself back in those days, and I'm like, even if I needed to talk to someone, where could I come up with the time to do that? I
Mm,
just had no time. Like there
yeah.
was no time left for me to even consider the idea of talking to someone because it's like you're busy all the time.
Yep.
Like when are you know, I remember my wife used to be like, you know, when was the last time you saw a doctor? I don't know. They don't open on weekends. And I can try to fit him in the weekend, but you're busy throughout Monday through Friday, you're busy, and then the weekend, most like dentists, for example, they don't open on Saturdays and Sundays.
Yeah, usually not even open on Fridays.
Right. So,
No,
it's a challenge.
It's a
when you're
real
in that
thing. And,
system.
and speaking of that, let's move over to like mental health as it pertains to personal injury, right? This is a
Yeah.
very real thing. You get in a car accident, you're worried about like my car. I'm worried about my job. If I'm injured, am I going to lose my job because I'm injured and I can't come in right now? You're worried you're in pain, which has its own psychological effects. How often do you see working so closely in this personal injury space and being an expert in this space, how often are you seeing like any type of psychotherapy or psychologist being included in the care team these days?
Unfortunately, I don't think we do a good job with that side of it. I think we recognize it, we see it, we sense it, but we don't really dive into it and address it heavily. And I think it's for two reasons, and that's just my personal opinion. One is because it's not something I deal with, so I'm not going to mention in my note.
Yeah.
And two is because there is this fear that the minute we say that there is some mental element which is legitimate, that somehow that's going to be used against the patient. Like
Yes,
you're faking the
psychosomatic type
symptoms.
pains, or
You're having a
even,
psychosomatic,
yeah.
right? So I think you got to be careful because and sometimes you might be asked by an attorney, are you a psychiatrist? Are you qualified to make that diagnosis? But the reality is, I don't think anyone go through a trauma, whether it's car accident or a sports injury, and not feel worried about their future. At a minimum,
That makes
there's
sense.
the level of
Fear.
fear
And worry. Yeah.
and worry about the future. At a minimum,
Yes.
let alone like what's going to happen to my job, my family, my income, all the other aspects. So anxiety, stress, probably among the earliest thing that patient will experience after a traumatic event, including a car accident, and then after a while that will start to develop into some sort of a depression.
Yeah. Yeah.
Right.
Unreal, like unrecognized and untreated worry
Yes.
turns into depression very
Yeah,
frequently.
but we don't do a good job, honestly, I think, in really diving into that and documenting those things. I notice when I do my office notes, we have the intake form and we have the review system, and we ask the question, do you have any of the following? Do you feel stressed, anxious? And more often than not, the patient actually mark yes.
Yes.
But now, having the luxury of having additional time, I can ask, can you tell me more about that? What are you concerned about? And then ask the question, did you have these problems prior to the accident, or are these just related to a traumatic event, more like a PTSD type of thing? And then most of the time they tell me, no, this is all new because of what just happened
Which
to me.
logically makes sense.
It makes sense.
Right. So I do think that that's something that's really important for anybody that's injured to be able to recognize that that is part of healing as well, not just the physical healing, but the mental healing and getting into a good place. So, you mentioned that, an attorney may ask you, are you a psychiatrist and stuff like that. So let's move into that space for a moment, and the fact that you do expert witness work and things like that. So, or even without expert witness, just the fact that you're dealing with these types of injuries, knowing that you may have to defend the care that you give to attorneys and things like that. So, as a background, working in in this space of personal injury, whether it's sports injury, car accident, whatever it is, injury, you have your work scrutinized a lot. Right? I mean, it's true.
It's exactly.
So how do you deal with the fact that that when you see a patient, when you're doing a notes, most of the time there's going to be somebody, whether it's an attorney, another doctor, or something like that, that's looking at that with a fine-tooth comb sometimes saying, is this necessary? How do you deal with that? How do you maintain really good confidence there?
Well, I think it comes down to I always say, facts are always going to be facts, and the truth will always prevail. I cannot fake certain things. Certain aspect of the examination, and I get asked sometimes this question, well, the doctor, doctor, don't you think, what the patient is telling you is subjective? So when you move their arm and say that hurts, that's subjective. I'm like, yeah, but I also detected reflexes that they cannot fake. The MRI findings, they can't fake. A discarnation, they can't fake a discarnation on MRI, that's an objective. So there are ways, but I think stick to the truth. I see sometimes, and I can see why the attorneys sometimes do that, is because there are times when I've fortunately seen notes where there might be exaggeration, and it can't tell if it's exaggeration from the person who wrote the note or from the patient.
Hmm.
So I stick to what I think is fact, truth, and it has to add up. Like we talked about earlier, like these, it's not one piece of information that
That
you
makes
rely on
everything.
that
Yeah.
makes everything. And you can't, like for example, one of the cases I was reviewing, let's talk about bladder function,
Hmm.
and they say, well, could that bladder problem had to do with the UTI? Did you check for UTI? I'm like, it is possible, but when you add bladder dysfunction with spinal cord compression signs, then it favors myelopathy from
Mm-hmm.
a disc herniation in the neck, because I'm not just looking at the bladder in isolation.
Yes.
I'm looking at it in conjunction with other things. And sometimes, the attorneys look at things in terms of black and white,
Mm-hmm.
and medicine is never black and white.
Yeah, as much as they want it to be, unfortunately,
Yeah.
there's an art to practicing healthcare.
And it's not their fault, because I understand that
What they're
from a
trying to
legal
do.
perspective,
Mm-hmm.
they don't need gray zone. I mean, there is always, hey, what is the probability of this versus that? Because they're trying to do their best as well to try to figure out, hey, but they need our help.
Yeah, I think one of the things that attorneys are taught but frequently don't remember is that reasonable minds can differ.
Yeah,
And so you can have two great doctors that see things differently. And
exactly.
and that's okay. That doesn't mean that, necessarily one's right or wrong even. It may be that they're looking at different components of the same problem.
Right,
And
right.
so really important there. So one of the things I think is important though is when you are looking for a healthcare provider, specifically after an injury or an accident, working with a surgeon or working with a doctor who's willing to advocate on your behalf is really, really important, right? So there's not all neurosurgeons are going to be willing to stand up and testify and be able to do that. Now, most of them are, if they're subpoenaed, and they're going to do that, right?
Right, right.
But somebody who is an expert in that field versus somebody who really doesn't focus on that is going to be prepared in a very different way to do that.
Right.
So I do think that's really interesting that people don't even recognize sometimes that what type of doctor they should go see. So let's just pause for a moment and say, like, for patients that may have been in a car accident, are all good patients? So let's say the sports injury, car accident, anything, are all of those patients good people to come see you, or is there a certain type of patient that really should consider coming and talking to you?
So I have a different philosophy now on how I do things. I went from the idea that I only want to see patient that needs surgery because I don't want to waste my time. Because if you don't need surgery, don't waste my time. That kind of mentality. Because I see myself as if I can fix spine problem, I should at least know how to prevent or how to manage non-surgical problem. And sometimes I also see my role as what you said, kind of like, you're an expert in your field. Maybe you're going to be able to help the rest of your colleagues and definitely the patient. So I don't have a problem with seeing patient initially to do an evaluation. And if that evaluation tells them you don't need surgery, that might actually lower their level of stress. At
Yeah,
least they can know
yeah.
from the get-go that I'm not going to need surgery for this, right? And that might actually help with their mental state. That I'm
Absolutely.
not going to be as nervous now that someone's going to tell me I need surgery at some point in time, and then just lay out a treatment plan for them. So I get a lot of referrals, honestly. Sometimes patients from the chiropractor directly before even seeing a pain doctor. I know we always talk about try this and then the surgeon is the last resort. But I've had cases where I was actually the first person evaluating them because it was a friend of a patient and they, by word of mouth, said, go see this doctor first. And then we guide them through the process. Say, well, good news, you don't need me, you don't need surgery. But here are what I think you need, and here are the good people that I would refer you out to. So I'm okay doing it. Maybe that's just me. I think some other, not all surgeons are going to think that way. They might say, no, if it's not surgical, don't waste my time,
Yeah.
kind of thing. Or it's not wasting my time, but I won't be as effective, I guess. But I see my role not just in fixing people through surgical means, but I see also my role in terms of help educating the patients and maybe assisting my other colleague from other specialties to navigate through the care of that patient.
Do you feel that, so when a person's in an accident and they have car insurance, or the other person had car insurance, and they're wanting the car insurance to pay for the care, which they, in this case, they should, that I'm at least proposing for the scenario. Have you found that when a case isn't prepared properly, a patient's care could not fully get covered for care that they should if the doctor's not doing a good job?
Yeah, and I think that comes down to documentation. I mean, documentation is key. And I know in the world of not enough time and we're busy and too many patients to see, most of us have adaptive templates. And some of the things that I've noticed when I do some chart reviews and record reviews is that a patient might be seen by a provider or a group for several months, and the physical examination is the same for all 6 months.
They didn't adapt the template. They just covered.
I'm like, so this patient for 6 months, they had the same exact exam.
And then on their last day, all of a sudden, it's a different one, and they're better.
Or sometimes they're even different exams. So sometimes I try to tell people, be careful with the documentation, because whatever you document is what we're going to go off of. So I think documentation is key in assisting with the case, because that documentation is what everyone's going to rely on to paint a story or paint a picture for that patient progression and ultimately their outcome. So, but we don't do a good job. For the most part, we're in an environment where it's too busy, too demanding, that sometimes we might not have the luxury to spend enough time to document properly.
Every single aspect of it.
Yeah. Documentation, I think, is the number one reason, in my opinion, or at least the main factor that determine a good case from a bad case, and not just from the provider perspective, but I also think from the legal attorney's perspective.
Yeah.
So,
I mean, even the patient perspective, right?
Yeah,
like
100%.
if the patient doesn't document all the things that they're feeling on that intake, and they're like, hey, this, like, if they're just like back pain, nothing else on there, and they're not giving you the information of when they experience it, and how they experience it, and what else is involved with it, they can't sleep at night, and how it's affecting their life, and all of those things, that can affect it as well, right? And so documentation is across the board
everywhere
important in those types of situations.
And to your point, there is also a big part that the patient has to play, which is not to say that this happens all the time, but there are times when the patient might not be giving you more detail or more information, because they might feel like, oh, I don't know if I should say this without my lawyer in presence. We've actually had some patients that we will call in to say, listen, I want to schedule it for a follow-up. Dr. Smith, Dr. Johnson referred you to us, and we wanted to schedule an appointment. I'm like, wait a minute, why are you guys calling me? I'm like, because we got a referral from your doctor. Oh, no, you got to talk to my attorney first. Because my attorney told me I don't answer a question without the attorney's approval. And so sometimes there is that kind of like obstacle where the patient feel like they can't say anything without the attorney's present.
Oof.
There are times also when I find patient, especially with personal injury cases, I always ask the question because I want to know, and we want to get to the truth behind the story. Have you had any of these similar problems in the past prior to this car accident, the pre-existing history? And sometimes they say no, and in reality they probably did. And sometimes they say, well, actually I did, but how is this related to this? I said, listen, everything is discoverable. Just be honest, be truthful, and we understand. We could have had injury playing sports in high school or in college or professionally, but we have to document that, and that doesn't mean that the new injuries, had nothing to do with this recent car accident, but we can't also omit that piece of it. If it happened, it happened.
Yeah, I think that's great advice in general for life, but especially in things for legal for all doctors and all patients is, generally speaking, if you just stick to the facts and the truth, you're going to be in a lot better situation. Yeah,
you got to stick to the truth. And, I always tell even attorneys that reach out to me, it doesn't matter on which side, defense and plaintiff, listen, if I'm going to take the stand under oath, I have to be able to defend my opinion. And if it doesn't make sense, it doesn't make sense. We've seen sometimes patients when, the patient has discrimination on the right side. Yeah, but the right side is fine. All their symptoms are on the left side. It doesn't add up. So I can't say, beyond that, I can't make a story. So we got to stick to the truth, got to stick to the fact, the truth. It doesn't matter what side.
Yep. It's just the facts are what they are, right?
The
And
facts are
you
what
got to
they are.
stick with it. Yep.
Yeah.
So, kind of staying with this theme of auto accidents and injuries and what any type of injury, let's just say. One of the things, like we've talked about conservative care a lot.
Right.
I'd like to go to the opposite end of that for a moment. Oftentimes when people are in car accidents, they may fear that they do need surgery. And oftentimes, I shouldn't say oftentimes, there are times they do need surgery.
Right.
So what are some of those most, if there is a pattern, what are some of the most common types of more severe injuries that may be benefited from surgery that come from car accidents?
I think one of the most common condition I see in my clinic that doesn't get as much attention, maybe in the early stages of the workup, is cervical myelopathy. And I think that
Can
condition.
you really quick describe that for everybody? When you say cervical myelopathy, what are we talking about?
So cervical myelopathy is a constellation of symptoms, a group of symptoms that develop as a result of pinching of the spinal cord in the neck region versus other part of the spine. And when the spinal cord gets pinched, I explain to my patient, think of it as like the spinal cord is the highway. All communication between the brain and the body has to pass through this highway.
Yep.
So if that highway go from 4-lane to 2-lane because there is pressure on it from a disc herniation, then traffic will slow down. So your brain is not going to be able to communicate with, let's say, your bladder or your legs or your hand in a way that allow you to maintain function. And doesn't have to be pain. Because I think a lot of time when we're dealing with injured patients,
Yep.
we're focusing on pain, pain, pain. And as a matter of fact, most of us in general, we measure our wellness by how much pain we're
The
in.
presence or absence of pain.
Exactly.
Yep.
If I have zero pain today, I must be healthy.
Yep.
Right? But if I have a little bit of extra pain, oh, something's wrong. I got to go see the doctor. Right?
Huge fallacy.
Exactly. And a lot of times I spend time educating my patients. So listen, I am looking for the neurological symptoms and signs that might tell me that your spinal cord is not working properly.
Yeah.
You might not have any pain, and that's irrelevant to me at this junction. Myelopathy is a condition that most of the time doesn't have a pain component with it, but it has neurological dysfunction, and that's what we try to detect. And especially when we see on the MRI pinching of the spinal cord, then we suspect there is myelopathy, and then through certain finding on the examination, we can validate that. And oftentimes, I start asking patient question, what I call it myelopathy screening, and they're positive, meaning they do have it.
So let's talk through that for a moment. So again, cervical meaning neck, myelo, Latin, is going to be spinal cord, and then pathology essentially is the last part of that.
Right.
So some form of pathology of the spinal cord in the neck is what we're talking about, and that's what you're saying is frequently not addressed as well as it should. So pain is what we look for normally, but there's so many other symptoms. Let's talk about some of those things. So what are neurological signs of cervical myelopathy? Like what are some things that if a patient's experiencing these, they should go, I need to look at that?
So for example, we assess 4 areas, and that's based on something called the Japanese Orthopedic Association Association Myelopathy Score. And those 4 things, one has to do with the dexterity and the fine motor skills on the arm. So it could be something as simple as, do you have trouble opening up a bottle of water? And they say, oh yeah, you know what, I can't seem to have a hard time. Or if you work with tools, do you feel that you have hard time working with smaller tools? Texting, typing, putting jewelry, buttoning up a shirt. Things that are simple require fine motor skills with the hands, and that's one question. Second one we ask is numbness in the hands, and it doesn't have to follow a specific nerve root or dermatome, but it could be in the hands. 3, bladder issues, and that could be urgency or incontinence. And 4 is some form of gait instability, a common one or a quick one that I ask the patient, if I were to have you take a flight of stairs and when you go to your car, you're going to take the stairs instead of the elevator. Can you go in the middle without holding the handrails or the wall? And say, oh no, I don't think I can do that. Why? I'm afraid my legs are going to give out. Those are kind of like some of the things that we discuss. Bladder, balance issues with the gait, dexterity issues with the hands, and then the numbness in the hands. Now, there are other reasons why you can have numbness, or one of those things, bladder, like we talked, UTI, bladder infection, a carpal tunnel can affect your hand. But when you put those 4 together, in the presence of an MRI showing you pinching of the spinal cord, and you do an examination and you detect certain thing on the examination, such as Hoffman, which is a specific reflex
Yep.
with the fingers, or jerking knee.
DTRs, yeah.
Yeah, sometimes I tap with my finger in the knee and the whole body jump.
Yeah.
Not just knee jerk, but the entire. That's a hyper state of excitation. So when you put it all together, well, now you have myelopathy. Those four areas, which is part of this Japanese Orthopedic Association myelopathy score, doesn't have the word pain in it. It doesn't.
Yep.
So sometimes I advocate to the chiropractors, to the pain doctor, please incorporate some sort of a myelopathy screening
Yep.
in your practice, because if you detect something about that, that might justify getting the MRI of their neck and see if there is compression. And if you find a compression, that could be a good reason to send to the surgeon and say, do you think this is a condition that warrants surgery now, or you don't think they need surgery at this point in time? But let's not just focus on pain, and forget the neurological function as well.
Absolutely. So, like, for people that may be experiencing those type of things, so obviously we want providers to be looking for anywhere through that care funnel that we talked about, whether it's conservative care, less conservative, or anywhere along that funnel. We want to make sure that we're looking for those neurological signs and symptoms. But for patients, you know, I think you did a great job of explaining what they can look for. So let's say that a patient's in a car accident and they hear this podcast and they go, you know what? I've been having some of those bladder issues, and I thought it was, you know, something else. I thought it was a UTI. I thought it was this, but it's associated with that. And you know what? I feel like I'm going to fall a lot more and stuff like that. Good time to go and talk to a surgeon, getting a consult with those. Now, let's talk about what can be done to fix that, and then what type of outcomes can we expect post-surgery as far as with those direct symptoms.
Absolutely. So myelopathy is, if left alone, it's a progressive condition. Typically slowly progressive or gradual progression, although in some cases it can be rapid. And I tell my patient a very simple example: water hose and plants. The water hose is spinal cord, plants are, could be your bladder, your legs, your arm, whatever. And then you put a brick on that water hose. The longer you leave the brick, that means the weaker or stronger the plants are going to get. The weaker. So now, the longer you leave the brick, the weaker the plants are going to get. That's affecting the plants. But let's talk about the water hose itself. The longer you leave the brick, the longer it might take for the brick for the water hose to bounce back once you remove the brick. And there is no guarantee. You might remove the brick and the water hose stay dented and never recover.
Yeah.
Why do I use that example? To provide them with important topics. One, there is a time element here, and we can't predict it.
Yes.
Two, the goal when you remove the brick from the water hose is to stop further damage to the water hose and further decline to the plants. But you cannot promise or guarantee that you remove the brick, the plants are going to turn green, and the water hose is going to bounce back right away.
Yeah.
But at a minimum, let's stop the progression. Yeah. And three, by taking the pressure off, we're just giving the water hose, the plants, a chance for recovery. So that's kind of the analogy that I use with them. Is
great explanation.
when taking that pressure off your spinal cord, I cannot promise you that you're going to regain.
And just
function.
because it won't regain doesn't mean it's not important to stop.
Yes.
Like you absolutely need to stop the damage and the degeneration.
Yeah. Exactly. And that's part of what we talked about earlier, which is setting up the expectations with the patient. So I tell them and I see them on the day of surgery. Why are we doing surgery today, Mr. Johnson? And they're going to say, because I have pain. No. Why are we doing surgery? Because I have compression of my cord. And what should we expect? We should stop it. Okay, if you get better after surgery, you had a good water hose. Your water hose was very strong, resilient, and it bounced back. If you stay the same and you come back in a year and say, doctor, I feel the same way I felt when I saw you the day of surgery, I'm going to give you a high five. Because we achieved the goal.
We stopped it from degenerating and progressing.
Exactly. So
that is a great analogy. I really love how you explain that, because I think that it's such a good way of setting the expectations with the patient and helping them to understand. And from what I've found, my experience has been, the better you can help the patient understand what's going on, the more compliant they're also going to be. Like you say, don't do this, you don't tell them why, they're going to do it. I mean, look at a kid, right? Don't touch the fire. They're going to touch the fire. Why? Because it looks interesting. It's exciting. But if you say it's going to burn you, it's going to hurt, and you've had pain before, and you don't want this pain, they're going to less likely touch the fire, right? So the better we can explain something of what they need to do. You need this surgery because it's going to progress if we don't fix it.
Right.
Well, the more likely they're actually going to do the right thing to get the surgery, because they go, I understand now, the goal isn't to stop the pain or to bring back function necessary, it's to stop it from progressing.
Exactly.
And I think that's so good. All right, so switching gears, one last kind of series of questions that I really love to talk about here. So, the name is Doctors Unscripted of the podcast, and obviously at Pain Doctor and, in our different brands, like here in Arizona Pain, we really focus on trying to help patients get out of pain.
Right.
But at the same time, a huge part of our focus is really trying to solve reliance on opioids and the opioid epidemic that we have. Yeah. And so one of the questions I like to ask to all of our doctors that come on are, what are some things you feel like we can do as a community of doctors to try to help solve the opioid epidemic?
One, I think we need to be open about it. First of all, we need to be open about having those discussions, that it exists. And I would ask ourselves, what role did we play? Whether did we add to it initially? Because I remember those days when you can prescribe 200 pills, right? They don't exist anymore, thankfully. But have a discussion about our role in whether we actually participated in making it happen. Is it what we learn in med school in our pharmacology courses and classes, and now it's just part of what you do? Things have changed now because there are courses, and now I think in the state of Arizona, every year all the providers have to take certain CME for opioid if you're prescribing them. Two, I think I start with looking for the root cause. And that's one thing that I actually started looking into carefully with all my patients. We talked about earlier about the discogenic facetogenic pain. One thing that I also started to recognize is the role of the fat muscle ratio. So I heavily now analyze MRIs. As a matter of fact, on the podcast here, I'm gonna welcome the neuroradiologist. I have not seen a single neuroradiologist report yet in our community for MRI lumbar spine commenting on the multifidus muscles and fatty infiltration into it.
Yep.
So now we start to mask problem by giving simple solution, which is easy to prescribe a pill, than to actually look into root causes, and it could be muscle fat imbalance. That could be also contributing to this whole idea of mechanical axial low back pain, facetogenic pain, and those people don't really need the opioid. They need to focus more on their muscles. So focus on the root cause, have the discussion. I discourage my patient, because when they do surgeries, they ask me, what are you going to give me after surgery? Then I'm going to tell something very simple. Most of the stuff I do are minimally invasive. I'm going to give you some, you can take Tylenol for mild pain. At most, I might give you a hydrocodone, and that's going to be just 7 days worth. That's it. If you have pain for more than 7 days, you got to come and see me, because now I need to know why are you still having pain. And then obviously a muscle relaxant like a Flexeril just to help with the muscles. So I don't think we need to be as judicious as we used to by giving out these medications. I don't see it as much now, at least in my practice. When I first started, which is years ago, I used to see patients in my clinic that are coming from pain practices, and they're on like these heavy drugs, like morphine, like really big drugs. Luckily, I don't see that anymore. So I think as a community, we've been doing a better job in tackling this issue, and maybe our behavior in prescribing this medication has also evolved over time, and it's not as judicious as it used to be.
Yeah, I think that's a great answer in the fact that as providers are more judicious as they're looking for treating the root cause, communication I think is really important, because we have such a fragmented healthcare system.
Yeah.
And so, somebody that's in pain might be seeing 3 or 4 different providers all related to the pain. Like, so if there's not good communication between them, what are you prescribing versus what am I prescribing? Like, what's everybody, and how does that all work together? And so I do like that answer, though, that in the end, if you treat the root cause, there's a lot less need for symptom relief.
Right.
right? Now that's not always the case, but it's very much, it's going to help most people, right? And
No,
I think that's
100%.
really
Yeah.
important for us to do.
And I add in my clinic, I add one thing. I always like to use the analogy like I like to stay in my lane,
Yeah,
and my lane is surgery, not chemicals.
yeah,
So when they come and ask me specifically about medications, I tell them, listen, you have a pain doctor. So to your point, instead of having multiple providers involved,
mm-hmm,
and I might be doing something that is undoing someone else's work,
yep,
I tell them, listen, why don't we just consult with your pain doctor? You're already
great
under their
idea.
care. They know you better than I do. They've been seeing you a lot longer. I only saw you once. And they are actually the expert in medications. They know the pharmacology, they know the dosing. I am not. So therefore, I'm going to defer that to the pain doctor. And I think by having a quarterback, I guess, for the lack of better term, like having that one quarterback that can manage the pharmacological component of pain management,
Yeah,
I think that's probably might minimize the issue of overdosing and overprescribing. So I just refer to say, listen, you have a great pain doctor. I know them personally. I know this doctor, and I would just defer that to them. Let them help us with this aspect. Just like when they tell me, "Can you help us if they need surgery?" I tell, "Can you help me if they need these drugs or no?" So
that's fantastic. So, in the end, doing surgery only when necessary, but when it's necessary, it's absolutely needs to be done is frequently kind of the recipe there. But as it pertains to what we're doing with managing pain, it's making sure that as a team we're collaborating, we're working together,
yeah.
we're communicating well with the patients, and I think overall that's one of the keys to making sure that patients are getting the care that they need. So, all right, well, as we wrap things up, one last question for you then. So, if you were not able to be a neurosurgeon, it wasn't on the table, let's take you back in time to when you were, in college still. What would you choose to be?
So growing up, I want to be an astronaut.
Love it.
And
Why?
I remember I used to get these like these Lego set, and
Mm-hmm.
I'll break them apart and I'll start building rockets because I was like, oh, that's cool to just go up in the go to the moon, and I just thought it was cool. And I
Mm-hmm.
guess I don't know, I think I was in elementary school. When was it? Like the Discovery, one of those like
Discovery
mission
Channel or
discover
NASA?
one
Oh,
of those
okay.
missions was a
Mission Discovery.
Discovery,
Yeah.
yeah. And then obviously my dad took us to Florida. We actually saw the
The space
Discovery, like
launch.
the space area. I was like, wow, this is cool. And then I was like, yeah, I want to be in it. So I guess now, I mean, maybe that was more of a childhood dream because it was between astronaut and pilot.
Can I ask you
Something about
what
being,
about the astronaut part really fascinated you?
it's the freedom of flying and doing something most people don't do.
Mm.
I guess, I mean, I'm always fascinated by the pilot and the flying because I think they see things that we don't get to see. I
Mm.
mean, and one of my good friends actually, he's married to my cousin. He's actually a pilot. I actually had dinner with him last week, and I started picking his brain. He's like, "Is it when you guys hit turbulence, do you guys like freak out?" Because we do when we're sitting there. He's like, "Oh no, that happens all the time." And then I asked him about the birds hitting these engines, and they go, "Oh no, that can happen." And we get birds hitting the windshield. But I told him, look, what is your perspective from the cockpit? When do you see Earth? Do you see like he's like, it's fascinating.
Mm.
And then he was sharing with me last week and was talking. He's like, there are times when he'll be flying, and he'll literally see like day and night next to each other, with a line dividing them.
Mm.
So that must be cool. So just having that kind of like seeing a world from an angle that you don't get to see every day, I guess,
Yeah.
is what makes it fascinating.
I also find that absolutely fascinating, but I would argue that as a neurosurgeon, you also have that same type of thing, which is that you see the world differently than most people. And the fact that you get to see things that most people aren't going to see, you get to do
Yeah.
things that most people aren't going to see. Maybe it doesn't have the same majesty of looking at the world, but the majesty of the body and the creation that you get to see and how it heals and how it goes through that. There is some similarity between
Yeah, I mean,
those
yeah, to
two.
some extent. I mean, the first time you touch a brain is you never forget that. The first time you put a hole in the skull to try to like do a brain surgery. That's
Yeah.
yeah, to some extent. Yeah, you're right. I mean, we get to do things and see things that most people don't get to see or do. So it's a privilege. I
Yeah,
would say it's a
absolutely.
privilege that we get to do what we do.
I've also been fascinated with being like an astronaut, seeing the world from outer space and stuff. So I can absolutely relate to that. But I also know that there's kids out there that their dream is to be a neurosurgeon like you are, and I just think it's really cool that there's usually, when we look back in time at what our different dreams were, there's actually usually some type of connecting factor that they all have a similar. And so, I always like to ask that question, but in the end, thank you so much for coming on the podcast. I think like the information you shared is absolutely incredible, and I think it can really benefit anybody that listens to this. So thank you for coming on.
Oh, thanks for having me. This was a lot of fun, actually.
Awesome. Yeah. Thank you.